I'm Aarondeep Gill, and I'm a senior biomedical scientist.
I'm Gabrielle Simpson. I'm one of the simulation educators.
And so today we're going to be talking to you about our project of using clinical simulation to improve major hemorrhage training. So in terms of the battle of the bleed, and I'll hand you over to Gabrielle first, who will talk to you about clinical simulation and its use.
Thank you very much. Let me see if I can actually use the slides. Doing well, brilliant. This came on the back of the shot that came out, I think it was early last year, and we were approached by Rachel, our transfusion practitioner, to put in some simulation training throughout the trust. So we did run a few out in the clinical areas, and then we thought we'd quite like to take simulation into the labs. We believe it's one of the first simulations in healthcare with healthcare scientists, and certainly was the first at GOS. So simulation in healthcare. So a little bit of background about simulation. So healthcare is actually the last high stakes industry to adopt simulation as part of its core training. So it's been really well utilised within aviation and the armed forces, and we draw upon a lot of their expertise to embed this into the hospital, into healthcare. The way I usually liken it is that you wouldn't go to a ballet and expect that the dancers haven't rehearsed, so why shouldn't it be the same in healthcare? There's a few things that we look at in simulation, so we're making sure that this is a safe environment for everybody to learn in. There's absolutely no assessment, there's no judgment, and it's an area that you can make mistakes. Yeah, so it's a safe environment to really go through the processes that we have within the hospital, and then an opportunity in the debrief to unpick that further and see what the findings are from that. So it's a very unique learning style. Research suggests that it actually has increased retention of knowledge versus more traditional didactic trainings. Is the use of actually doing the task, but also the debrief afterwards. It allows for multidisciplinary training, which I will let Aaron talk about a little bit later on, about some of our future goals at US. So it's really exciting. But ultimately, why do we do simulation? It will go down to that patient safety. So as well as looking at systems, it also looks at team competence and performance. So I'm just going to talk about patient safety in this more depth. So system safety and simulation is something we've developed quite a lot, especially since the pandemic. So it's focusing on, have we got everything that we need in the right place? It can help familiarization to new or unfamiliar places, and aims to identify latent safety threats. So if there is a risk for patients, it has a knock-on effect on staff and patient safety through learning through mitigation improvement. So we've got two elements of safety. So the safety 1 and safety 2. Safety 1 is probably that more traditional safety model that we're all familiar with, in that there's a few things, the theories of as few things as possible go wrong. So it's quite a reactive model. It waits for something to happen before it fixes it. Whereas if you look at safety 2, it looks at limiting performance variability within the system as it exists. So a safety 2 approach seeks to look at daily practice of human interactions with the system, and can highlight ways to optimize system safety in order to make it work for the people that are using it. It tells us that we cannot manage safety and improvements if we don't know the specifics of how things work in practice. So the system safety work ties in really nicely with business contingency planning within the laboratory environment. And so we use this model combined with a more traditional, what we call immersive model. There's a nice little picture of everybody who was there. Our immersive models are in situ training, is where we look at team working and communication, and then within the labs it was really useful to bring in the system safety as well, so we merged the two into one. So communication and simulation is one of the primary factors that we look at, as well as systems. So it promotes use of sharing that mental model, and I think that's something that's really useful if we apply it to training such as a major hemorrhage, especially with the conversations that will happen between the BMS in the labs and the clinical person who's making that phone call. Within a phone call, we haven't got non-verbal cues that we might have if we were face to face. So it's really important that we are sharing that mental model, saying like, this is why I'm taking a little bit longer to do this, because I really need to have X, Y, Z. And then that focuses onto that closed loop communication. So I think the best example I can give with the importance of closed loop communication. So that's very much like, Aaron, can you go away and do this for me and come back and tell me once you've done it? There was an incident out in Toronto with a child with a cardiac BT shunt, and it was clearly blocked. So as we know, the immediate intervention there is to give 50 units per kilo of heparin. So somebody asked for 50 units per kilo of heparin to be administered to a patient, and 2 members of the staff did it. Unfortunately, this did not have a very good outcome for that patient. So it really focuses on that importance of making sure whose responsibility it is in those stressful and crisis resource moments. So within the debrief, we use communication to really explore the challenges that are faced with us within healthcare, and it really is an open environment to discuss learning points and how we can apply them. I won't give any spoiler alerts. Aaron will talk about the latent safety threats that we encountered when we ran our very first simulation in the labs. To begin.
Okay. The reason that we mainly wanted to go with clinical simulation to support our major hemorrhage training is because we had identified that there were shortfalls to the current laboratory training. So one of these was that the current laboratory training was not very realistic. We had limited resource, paper photocopies of units for issue, no real feel for clinical input or the use of the lab systems fully as they would operate in a real situation. Another limitation was that we had limited scenarios. So the scenarios were limited to chessboard-like demonstrations and game scenarios rather than based on real-life events. Whereas with clinical simulation, and when we were deciding on how you would run a major hemorrhage, they're often based on patients that we've experienced before. So then it gives our staff a more accurate training method, and it's also pertinent to your center itself, whereas like a major hemorrhage in a paediatric center is going to be completely different to one in a major trauma center, for example. We also had limited clinical input, so the laboratory major hemorrhage training rarely coincided with the clinical major hemorrhage training. So often when they were running a sim up on the wards or in PICU or wherever else, in the laboratory, we kind of knew there was going to be a hemorrhage taking place, but the actions that followed it up, other than providing a dummy flying squad unit, it wasn't very accurate. And another thing was that all of the training was not done in real time, so you weren't taking in those factors of processing real-time samples, how long it took for units to thaw, and whether you're assessing your stock, which, as we know recently with the Amber Alert, we need to know what's exactly in our fridge and how we would deal with that, say if we were running out on certain requirements, which again, in a paediatric center, there's so many things to consider with that. So our first experience involved liaising with the simulation team, which was Gabs. So what we'd done in the first instance was arrange an initial meetup. And this gave us an idea of what goes on clinically in a major hemorrhage sim and how that can be translated to the lab, as well as resources that are available in sim that we may not actually be aware of in labs. And by talking, we've actually come up with lots of things and new ideas that I'll go on to discuss later. The second thing we did was set up a scenario. So we thought for the first major hemorrhage sim, we wanted to keep it extremely simple. just to see if the principles and the SOPs and how we should be covering hemorrhage in the lab was working, and whether the clinical simulation principles could be included and work well with lab training. We then went on to arrange a second meetup, which assessed the scenario that I created as the subject matter expert for any improvements ahead of the simulation, so we could compare it to other clinical simulations that may have some sort of relevance and that could be comparable to. And I'll go on to discuss that on the next slide, in how I set up the different types of targets in there. And then we had a brief before the first sim, which we prepared test patients and the test limbs for functionality before we completed the first scenario. So then the decisions that I had to make before we went ahead. So the way in which sim was set up for a clinical setting, it came under all of these 4 main headings. And it made me create a template in which we address the technical objective set. So how to issue, so for our scenario, it was how to issue emergency red cells, how to issue emergency platelets, and how to issue emergency plasma products. Non-technical objectives, knowing how long the plasma took to thaw, how to fill out our HFM 336, which is the protocol we record our major hemorrhage on and the different rounds that go through, how to inform the Heme SPR and the Heme Lab BMS to know that there was a hemorrhage going on, the theory and how to obtain concessional release, how to order further emergency components, and how to fate the flying squad units. The next thing to do was discuss our patient background. So for this scenario, we went with a patient that had no sample. It was a brand new admission, so we didn't take into account any of those ordering things in terms of samples and running the samples. And it was just to address really emergency component issue and see how we could get one of each of the type of product out to stabilize a patient that had crashed onto ECMO, for example. And then the final thing was to determine the vital intervention. So these would be things that we'd interrupt the sim for, and we decided that an incorrect product issue would require an immediate intervention and would stop the sim and then take it from there. So the key learnings from the first experience, we found that we couldn't use the bleeping system in which we'd routinely get a major hemorrhage call. Rather, we replaced that with a bleep to 0590, as this was deemed more appropriate. The patient details, we realized that we could have put a little bit more thought into our patient details, as we forgot to address the weight of the patient, and this wasn't included in the communication from the clinical area to the lab, and the BMS that was involved didn't actually ask for that information either. The contact details from the BMS were also missed for the clinical area, as they kind of knew they were in a simulation situation. We knew that it'd come from the specific caller that was calling to say there was a hemorrhage, whereas in the future, on my next slide, I'll discuss about tying in with the clinical area and us. We didn't take into account the collection of components, as we had nobody collecting the components, so that's another key learning. The issuing of components, and this is one of the most interesting one, is that even though we had prior checked all of the workings in our laboratory limb system, in our test system on the day we encountered printer issues, which prevented us from printing the labels, but then it went on to make us actually test our downtime processes and see how they would work. Also, we discussed informing the Heme SPR. It was done in theory, but not an actual role, so there was potential for including that in a future one. And our downtime processes, so the sim prompted investigation of our downtime processes, and we found one of our key findings is that on our downtime labels, we had them pre-set up on a Zebra printer, which prompted like the addition of your unit number, and all those kinds of things, which is printed onto a downtime label. However, when the BMS went to do that, we found that it was actually only limited to one PC, and there were multiple labels and copies of the same kind of label, so it became very confusing for the person issuing the units. And then again, with our test limbs, we had the printer setup issues. So our future goals. As we discussed earlier, we'd like to do improvements to our patient design with the height and weight oversight that we had in the first instance. And the way that we discussed actually doing this in the future would be taking real life scenarios and then adapting those to the sim situation. Improvement to clinical area involvement. As the call station wasn't manned during the mock sim, we had issues with in the rundown and how we reported back. Secondary product, so we could add that into a future goal. Second sim could involve using follow-up products and how we'd go with the more complex bleed. In turn, with more complex scenarios, so including antibodies and real life samples that we can create with antibodies in them, and what we would do in those situations. Blood collection, there was a potential to include the clinical teams and in collection and the portering teams, and the printer issues. We thought a potential another scenario that we've experienced before that we needed to apply to major hemorrhage training would be to have a complete system downtime and how we would do that. Monitoring stocks, as we mentioned previously, the Heme SPR involvement, so to include the Heme SPR in future limbs and test that in sync with what was going on in the laboratory. Return of unused components, which is another aspect to add into future limbs to make them more realistic, and to include the fating of the emergency limbs and how we can tie in with the clinical area and getting that information. Another more exciting aspect was the investment into realistic products. So me and Gabs were talking yesterday of what we could do in terms of having fake plasma we could thaw, realistic looking platelets, and we were talking about Facebook forum yesterday, which has different ways that you can make plasma look real and platelets look real and all those kinds of things. And ultimately the joint up sim goal, which would be to have the clinical simulation in the clinical area running in sync with the laboratory one. So I think I just popped onto, I saw one of the questions in the chat come up to say, was this run in the clinical area or the lab? So our first one was run purely in the lab, but the goal is to actually have both the clinical area and the lab running in sync.